Good. So, Kevin, we're here today to talk about Ontario healthcare, talk about the perspectives we're bringing. Um, what's the position from which you can look at the system, and what are you seeing?
Well, you know what, I think the system is always evolving, and we hear many challenges within the system. I think we have a new government in Ontario that's just focused on hallway medicine for a reason. That's a symptom, I think, of an underlying malaise, which is flow. And clearly we want to improve those issues, and if we're to improve the patient experience, and equally, I would say, improve the quality of work life of pretty beleaguered providers these days.
Yeah, I mean, I think we're kind of now starting to see the role that communities can have in actually bringing forward solutions. You see towns and cities now starting to talk about being in the healthcare game because they see the link between social care and social services and healthcare. So I think slowly things are starting to come together a little bit more, and I think we're starting to accept a healthier provider. A provider's got a lot more wellness as an actual goal of the system as well.
I agree.
Now, UHN's Canada's largest research hospital, how does that affect how you see what happens to patients?
Well, I think the exciting part of being a very research-intensive hospital is you're not only looking at the privilege of treating each patient, but how do we take that patient experience, learn from it, and improve care? We also know that we have the capacity to look at new technologies. And one of the great things about being at UHN and the University of Toronto is that you can bring together groups of experts that you just couldn't imagine anywhere else. Disciplines that you'd perhaps never have dreamed of. With the Vector Institute coming along, we really can be and are becoming a leading environment in research for artificial intelligence. And then at the opposite end of the spectrum, remarkable science at the molecular basis of disease in areas like cancer through Princess Margaret. So it's a remarkable opportunity. But we face some challenges. We know we're facing some economic challenges, and those are likely more to come. I think we're pretty shocked this week about General Motors.
Right.
But for me, that's a big reason why more than ever before, we need to focus on research as the economic driver. That those old manufacturing jobs, which were terrific and fueled our old economy, sadly are leaving. Right. And the high-tech, high-quality personnel jobs really are those of the future.
So as you sort of look at these challenges, I mean, we see things from the same way, actually. We see the social determinants of health at the School of Public Health. We see the way the healthcare system has management or leadership and can get that flow through the system. And, at the Dalla School, we're lucky that we work really closely with hospitals and other partners across the system, but it's a consistent perspective. We're not getting people moving through the system.
Right.
We're not ensuring that there's the kind of seamless transitions that we want in terms of patient experience and engagement. And we're not getting ourselves ready for the next way that we're going to see our economy work and the next way that we're going to see our society work. Now, obviously, you and I have written together on patient experience and engagement. Where do you feel we might be able to improve patient experience and engagement across our system?
So my experience would say where we often let our patients down most, or in their families, is at the points of transitions of care, and or when we're dealing with multiple illnesses or chronic conditions. And I think the more opportunity we have at those points of transitions of care to eliminate dropping the ball or make sure that the process of care actually is smooth and continuous. And we've all, either in our own families or heard of upset consumers who say, well, when I left my primary care provider and I was going to the hospital, I was told this, and that isn't what happened. And if I was admitted to hospital and I was leaving hospital, I was told to expect this, and that isn't what happened. And each of those steps weakened the consumer's experience, the patient's experience. So for me, as you know, I'm a devotee of models of integrated care. And I think the more we create a seamless team, moving from healthcare, as you've said earlier, into health and social services, the more we're going to improve the patient and family experience.
And for those just tuning in, we're discussing Ontario healthcare, the challenges that we're facing. But now we're, I think, really coning in on this issue of transitions and integration of care. I mean, we see, I think, when we look at the data, when we talk to patients, when we do the work that we do, we see this same sort of pattern of individual experiences of excellence. Most Ontarians are happy with care when they get that care, but great challenge moving between all the different points in that care. And fundamentally, at the end of the day, it's no one's job to steer through all of that, and it's an incredibly complicated system. I thought one of the things that we can really do is start to ask patients and their caregivers how to steer through that, and that can allow us to create the system and the incentives that help them move through that system much more easily. I don't know how you see the ability for kind of hospitals to improve that transition back to the community.
Yeah, so I don't think there's a better arbiter of quality of care than the patient and family. And one of the things I think we can do a way better job of is tell patients and families what to expect on each respective day. And if it doesn't happen, I don't think anybody's going to be more interested in following up and saying, Dr. Brown, you told me today that I could expect this. It didn't happen.
Right.
So how do I make it happen?
Yeah.
And we've been so resistant to that in healthcare. We better not tell people those things, because if we don't do them, they'll figure it out.
Right.
Well, I think they're figuring it out, and I think their expectations are also they want to follow a care plan. They can download a care plan on Google at any moment. So I think recognizing that patients and families are great arbiters of quality and process, tell them what quality looks like and give them the process, and they'll remind us if we drop the ball.
Well, I believe the right thing to do is to find a way of listening consistently and in a thoughtful and reflective way in what patients and families and patients and caregivers are saying. But I think the necessary thing to do is to also start to measure how we're doing against that.
I agree.
And I think that's got to rise to be one of the central goals of the healthcare system, that when people talk about their system, they actually feel confident not only in the physician or the nurse or the therapist in front of them, but they also feel confident that the system is going to be able to respond to them and will help them move through. And even the system eventually will help them stay healthy.
Right.
Which I think we still underinvest in as we look at our systems.
Well, and if you want to understand the system, look at how we incent it.
Right.
So I think increasingly, if we go back and look at incentives, that sometimes if you follow the resources and incentives, you understand the behaviors.
Right, but this is something we were talking about earlier, and you said you can't get on a plane and go to the right system.
No.
I think we've had a very good job of constructing incentives that don't help us get where we need to go. I think we've now got to find ways of really using those incentives to empower clinicians and patients to kind of work towards the care that we need.
Absolutely.
Look, the other thing is that you and I are both, although on opposite sides of the relationship, there's a very tight relationship between hospitals and universities, particularly the academic hospitals of Ontario and the research-intensive universities across the province. How do you see an opportunity here to be kind of more than just a collection of good or excellent institutions?
So for me, and I think for the Council of Academic Hospitals and the Toronto Academic Health Sciences Network, there's a real push on understanding commercialization as opposed to only focusing on scholarship, which is incredibly important in and of itself, as I know you and I agree. But when you take the collective of the academic teaching hospitals and research-intensive universities of Ontario, we know the return on investment is among the best in the world for science. What it isn't is among the best in the world for translating that science into commercial enterprise.
Right.
And I believe, as I know you and many others, we share the view that as we start to think about that new economy, that academic hospitals need not only be drivers of cost, but centers of commercial enterprise that will attract venture capital to Ontario and ultimately jobs to Ontario. So I think we have a lot of work to do, not only within our hospitals and universities, but with our government partners to create a taxation environment that says, hey, venture capitalists, you should come here because it's the best place to do business. It's the best place to translate invention into commercial enterprise. And that will fundamentally change our economic structure by highly qualified jobs in highly qualified professions.
Yeah, I see it as something where if we actually make Toronto, which should be such an attractive area for all sorts of types of new cutting-edge research, really the global destination, we'll draw more treatments in for patients. And it's not a question of when the treatment gets to Ontario,
Right.
it's actually, it always starts here.
Yeah.
And our patients are always getting access to that cutting edge treatment.
Totally.
And I think once we create that environment that builds that, or that links that great scholarship that's across the universities with the clinical environment where it gets played out quickly, I think that really starts to create a bit of magic for how the system can work. But I think the other challenge is that the healthcare system is changing. If you look at the way just simply the practice of medicine changed from, say, 1950 to 1990 or 2000, that's a relatively small amount of change compared to even the last 5 or 10 years. And we need to be constantly re-preparing and re-educating and supporting providers.
Yes.
Getting back to this idea of how folks find a strong and resilient and supportive workplace so they can kind of meet these challenges. And part of it's the new science, part of it's the new treatment, part of it's the role in actually helping manage the transitions of care, and increasingly the systems of care that sit around all the institutions that play here. And so I think it's a very long-term relationship that needs to be built, a much more intimate relationship that needs to be built that really will help all the boats rise as we try to go towards the healthcare system that we'd like.
Well, when we look at, for example, every man and woman working in a emergency room today, I know that not many of them looking down the road are thinking the world is brighter ahead, right? It's going to be easier, there's going to be less patients, there'll be less complex, that isn't what we see or fear. So I think that the resiliency of what's happening to our population and the resiliency of what's happening to our providers is going to be absolutely essential. And just now, we're really starting to see this as a foci.
Yeah.
So we're talking more and more and more about stress and post-traumatic stress in healthcare providers and first responders. And if we're going to have a healthy healthcare system, we absolutely have to think about the health of those people who provide that care. To your point earlier around invention and innovation and keeping that science here and finding different ways to fund an increasingly expensive system. Soon it'll be 100 years since we invented insulin at UHN and the University of Toronto,
Right.
Another great relationship. But you and I know today the 3 largest manufacturing countries of insulin do not include Canada. Germany, France, and Denmark. That's a $50 billion a year industry. And when you think about the corporate tax structure that would allow us to invest into a universal system, protecting universal health care in a model of commercialization is going to be an incredible challenge, but I think it's what makes most of us excited as well.
And so we have a question from Nancy about how we cope with an aging population and how we work with different types of providers within that. I mean, you and I both spend a lot of time working with providers in training, making sure that doctors, nurses, nutritionists, therapists get the education that they need.
Yeah.
How do we start to work with different providers in our system more effectively?
Well, I think first of all, what do we mean by alternate providers, and do we have or do we want a scholarly base for alternate forms of therapy? I was meeting with a fascinating colleague yesterday, Dr. Angela Chung, who has an integrative medicine chair at the University of Toronto and works at UHN. And she's doing amazing work in saying, what does the role of traditional Chinese medicine or indigenous health or perhaps non-traditional Western medicine techniques mean? Because many, many, many of our patients are choosing to use that. Secondly, I think a scope of practice, if you think of that as a part of alternate provider, we know we are not pushing hard enough to say who is the crassly least expensive, appropriately trained person to extend the most expensive, highly trained person. And I don't think we're going to be able to meet the needs of an aging population if we don't re-examine scope and recognize that there is a lot more that can be done with our very, very expensive resources being spread over a larger population and using technology to support that.
Well, I think this all comes back to this issue about the work life and the experience of providers, right? We looked years ago at data around burnout in nurses, which is, for a long time has been a very real phenomenon and a real problem. When there was a strong teamwork environment where groups of providers could work together, you actually saw much lower burnout. It creates a whole different environment when you can talk about providers as a team and not as kind of professional silos. Anyways, I think we're getting close to the end of our time, so I want to thank everyone for joining. Kevin?
Thank everyone for joining, and we look forward to doing this again soon, and send us your questions.
Great, and we're going to be trying to cope with the emerging amounts of evidence and the volume of stuff coming at people. We've got a health policy blog at healthpolicyblog.ca, and I know that as we're setting strategy here, and I expect for you as well, that it's going to be something we're going to be trying to reinforce, this idea of experience, engagement, and transitions.
Yeah. We are all, I think, also focused on our individual strategic plans at UHN, at the Dalla, Lana, but also with the province of Ontario, right, who are really starting to say, where do we wish to go? And what's our promise to the people of Ontario, and how can each of us play a role in that, both in shaping it and, as importantly, implementing it.
Great.
It'll be fun.
Thank you.